So keeping us right on, I want to welcome Risa Cashmore. She's been a nurse for over 35 years. She's a graduate of the Toronto General Hospital, where she worked in ICU and transplant and was a teaching master for critical care postgraduate nursing. Again with the glasses. As a provincial consultant for a visiting nursing agency prior to enduring SARS, Risa has maintained her CIC certification since 2004. She's a Bachelor of Life Sciences from McMaster University. She's received her Canadian Nurses Association certification in community health nursing in 2006. And she's served as a secretary for the Community Health Interest Group of IPAC Canada, was a former president of Chica Handic, which is now IPAC CSO. Risa was an infection control specialist for Peel Public Health prior to joining the Regional Infection Control Networks of Ontario in 2008. And she's currently the infection control consultant for North Simcoe Muskoka Infection Control Network of Public Health Ontario. That is quite a handle to say. She's the proud recipient and very deserving of the 2012 Chica Handic, or as I said, IPAC CSO Hygiea Award, in recognition of her exceptional efforts, interest, and commitment in promoting the field of infection prevention and control through the example and leadership. Risa is an amazing educator. I am have seen her speak many times. I've had the chance to travel around with her a little bit, and she's really willing to do what it takes to get her point across, whether it is dressing up, singing, she will play games, and she does do quizzes. Anything she can do to get her point across. So I'm sure you're really going to enjoy her talk in disinfection and sterilization in the community. Please welcome Risa.
Sorry, no games, no skits, and I just was worried about that little man under the table. Okay, and I heard that this is the worst spot to speak in before lunch. Nina Spencer, who's doing our keynote at the end of our conference this week, said a couple of weeks ago that it's the trout time, because people are like this. And they're waiting for lunch and they're falling asleep. So, okay, I won't stand in my head and blow bubbles this time, though. Okay, this is my disclaimer. I have nothing to disclose except that I went to Lower Deck last evening. So, I do have a few objectives. They were in your conference brochure. And what I want to do is apply best practices for you to community settings. So I'm curious, how many of you are working in the community? Like, nobody. Oh, there, at the back as well. Darlene at the front, and then somebody, oh, there, good. We've got somebody else at the back. So this may be a little unusual for you. So you work in hospitals? Okay. Long-term care, public health, EMS, I know a few, and community probably picks up the other, right? So this is to show you some of the differences in community healthcare settings, and I'd like to share with you one of our own IPAC Canada position statements and practice recommendations, the processes we went through, and talk about reprocessing when there's no MDRD, no central area where the equipment can go. And how are we going to manage that? So I would like to share some reprocessing stories for you. And community will mean home care and clinic setting for the purposes of the examples. So I would like to stop and think about all the medical equipment and devices that you use in your healthcare setting. And if you're in a hospital, you probably would think, oh, I can't even count. I can't count how many pieces of equipment I have. Long-term care, I know in one region in Ontario, they actually went through every piece of equipment, right, Justin? And you counted all those pieces of equipment and said, all right, who owns reprocessing it, and how are we doing it now, and how should we be doing it? How are we using it? How should we be doing it? And that's very difficult. It was still a big project, and it took you how long, Justin? A year, maybe, to go through that process? Yeah. And in the community, because we are going from home to home, for example, there are fewer pieces of equipment that we would take from home to home. So it might be a little bit easier to count those pieces of equipment. In clinic settings, you have other pieces of equipment, but it would be easier also to look at those and do this evaluation. So I was hoping to light a fire under the community people who are here, so there are a couple of you, to urge you to look at your equipment that you have and consider what you're doing with it and how it should be reprocessed. So we have challenges in home care, for example. There are no supply carts. You have to carry the equipment with you from home to home, or perhaps there is a system where medical equipment may be delivered to a client's home, or there may be a supply depot process where somebody goes and picks up the equipment or whatever. So as well, if you were using equipment and it was soiled and it had to be transported to a place for reprocessing, how would you go about doing that? And there, in fact, there's a CSA standard on that. So you could look that one up too. Thank you to Linda's for talking about those CSA standards. And there's a new one that just came out March 2014 for reprocessing in the community. So you community people, it's a great document because it goes through step by step for you with the practical applications in the community setting. So for you to reprocess properly, you would need a reprocessing area. And you saw some wonderful pictures in the Linda talks about, these big sinks and big areas, and there were people all dressed up, and there were dirty areas, and there were clean areas. Challenging to do that, to find that, to create that in a clinic where all you may have is one space. And I gotta tell you one of my stories about a clinic I went into, and they said, would you come and help us out with our infection prevention and control in our clinic? And I said, yeah, I'd love to. And this closet that they had, there was a little, like a milk chute. Remember milk chute? Well, okay, so on the other side of the closet was the washroom where the urine samples went into the milk chute, and then those specimens came in and onto a counter. On the same counter was a container with a high-level disinfectant in it, and the steam sterilizer right beside it in this area. So we had clean and dirty all in one spot. So I said, oh my, we have to look at this and start again and look at that workflow. And that CSA document, the new one, has a great diagram of a really practical way to set up a reprocessing area in a small space. But you also need supplies. You saw all sorts of things called integrators and indicators and all those chemical, mechanical, biological indicators that you have to do. And if you don't have that equipment, should you really be doing the reprocessing yourselves? So a lot of time in the clinic setting, there would be the challenge of, I don't have time to reprocess this. I'm going from room to room to room in a given day, and I have so many patients coming into the clinic today, and it costs way too much. We don't have that budget in our clinic, and the physician won't let us have that money to do it, and that's what I'm hearing. I don't have enough room. You heard about some of these closets, and I don't know how. And so these are some of the issues. There are also types of clinics that are set up where clients just come for wound care. And so the nurse sees the same client during their course of healing that wound. And there is a practice of the client's supplies being left in the clinic, and they're actually, some of the gauzes and the medical supplies and forceps are actually put inside an envelope with the client's chart. So when the client comes back, were you horrified? I heard a groan over there. where the envelope comes out of a filing cabinet, and when the client comes to clinic, then their stuff comes out, and then it's used for that client. Well, it is dedicated to the client, so we have to think about that part, and we have to think about the risks associated with some of these processes. And often there may be a need to do a packing, for example, in a wound, and sometimes there isn't a supply of something like a sterile scissor to pull out a sterile packing out of a little jar or something. So how are they going to get that packing cut to the length that they need? Because in the community, they're usually not supplied with a 1/4 inch by 3 yard or a 1/2 inch by 1 yard or whatever it is your packings are. They often will get this jar with yards and yards and yards of the packing. It starts out sterile, but once that lid comes off and somebody's poking in there, how do you keep it sterile as you cut subsequent pieces of packing off? Big challenges. But when we look at safety, it's the safety we're looking at. The reason we need to reprocess correctly is to be safe. So the expectations for safety are the same regardless of where a procedure is performed. You know, it could be performed in a hospital, it could be performed in long-term care, it could be performed in a clinic, but it could be performed in home. So the method, the level, and the products necessary need to reflect that intended use, and we have to make sure that these instruments are safe. So IPAC Canada started a community healthcare interest group back in 2007. And at that time, we struggled with the definition of community. We knew what it wasn't. We knew that it wasn't hospital. We knew it wasn't long-term care. We knew it wasn't EMS or the pre-hospital group. But was it just home care, clinics, public health, correctional services? It could have been any setting. So we wanted to come up with a position statement and practice recommendation about a little bit about reprocessing to try to meet these needs and the unique needs of these unique healthcare settings. And this is the first paragraph in the position statement talking about multi-use equipment and medical devices that they have been, all of them have been linked to increased infection risk if they're not reprocessed properly. And so you have to clean and disinfect, that two-step process that we're talking about. And we zoomed in on non-critical equipment because that seemed to be the majority of the equipment that community agencies were using. So can anybody think of a piece of equipment that maybe a home care nurse would bring to a home? Portable blood pressure cuff, yeah. Oh, foot care equipment, yep. Foot care, yeah, for sure. Foot care, Linda over there. Stethoscope, yeah. There are other pieces of equipment that you might carry with them, like a ruler and, pardon me? Suture removal, scissors, yeah. So there are a number of pieces of equipment that might come in, and Dr. Satar, I hope you get a few $1 million more to do some research about the risks of infection in community settings. Would you mind looking for that next if you're looking for a project? It would be good. Okay. So we don't know the risk in the community setting of what we're doing as pieces of equipment go from home to home, but we can extrapolate what that risk is. We do know that there are lapses in infection control in clinic settings, and those hit the media. We've heard a lot about those ones. And so we know the risk associated with physician offices and clinical office settings. So I just wanted to let you know you can go on the website for IPAC Canada and find it. And so we needed to zoom in on the principles associated with reprocessing. And we zoomed in on non-critical because we knew that semi-critical and critical would have to be dealt with at some point along the way too. So they're starting with that list, identifying the non-critical equipment that's being used, and look at how appropriate, what is the appropriate frequency and of cleaning, and what is the cleaning and disinfection method for that. So I'm thinking back again to Dr. Satar's talk about pathogens on surfaces and how significant they are and how these things happen. And I'm thinking about another clinic. I think it was a talk I gave to a family health team, and a nurse came up to me afterwards and she said, "Do you mean that vinegar isn't good enough to clean all the surfaces and kind of wipe off the equipment?" I thought vinegar was a good disinfectant, and it's environmentally friendly. So we had to start at the beginning with that. So written policies and procedures are very important, and this is really key. Don't buy that equipment until you know how you can clean it. And we did hear one of the speakers say earlier this morning, Louise and Michelle were talking about they don't even have control, and they're in control of their product purchase in their setting. So that's such a challenge to do, but it's important to try to find a way to do that gatekeeping. Audits, we all know, are very important, and part of that's part of the quality improvement process. And of course, you've got to use these hospital-grade disinfectants. So for non-critical, it would be a low-level disinfectant. And then we thought, well, let's translate this into a practice recommendation. Of course, you've got hand hygiene, you've got to, then we talked about the principles of cleaning and low-level disinfection, looking at Spalding's, the visible soil, and when it should be cleaned at each step. And two-step process always, risk assessment, documentation, and going through these pieces that I just mentioned. And then we talked about the materials and designs of equipment. And it isn't just nursing who's going into homes, it's personal support workers going into homes. You have physiotherapists who might have acupuncture needles going into homes. You have scales, you have speech therapists working in schools. So it's therapeutic tools, and that's something we discussed yesterday in our interest group, that some of these therapeutic tools are a challenge to clean and disinfect because they have so many little pieces. Could be a child needs to have a game and they have little men associated with the game, and how that can be cleaned and disinfected, or perhaps laminated cards. And how do you clean and disinfect a laminated card that's used for part of speech therapy? So we also referred people to the IPAC Canada toy position statement as well, and made a few other statements. And don't take extra equipment into the home, just like in a hospital room. You don't take all that extra medical supplies and equipment in, and it'd be great if you could dedicate equipment in the home, leave a blood pressure cuff in the home for the duration of care, and then it would need to be reprocessed as it leaves the home. And I already mentioned the transportation of contaminated equipment, and quite often there are contracted providers beyond perhaps the home care agency who goes into a home, and those contracted providers are also accountable to follow the reprocessing steps for all those pieces of equipment that go in and out of the home. So anybody who works for a community agency that's a funder, if you're using having a contractor, you want them to follow best practice guidelines. And we have equipment bags that go into homes, and there's stuff in and on the bag. And so where does the bag go? And does anybody ever clean those bags and disinfect those bags? And I'm seeing some of the EMS folk, and I know they've started talking about cleaning and disinfecting the paramedic bag, for example. So, like, who knows what's on those bags? But actually, there are two studies that out there that do talk about the pathogens that are on the equipment bags that can go into homes. And they've counted the number of human pathogens, and the longer it's used without being cleaned and disinfected, then the more pathogens are going to accumulate. But what is that risk? So that's another research thing for Dr. Sitar for us. And, you know, there are some homes that clients have the right to live rough. They can have all the varmints they want in their home if they want, and they can have all the soil in their home that they want, and they can have the mud and the accumulation of their belongings that they dearly love in their homes. So it's a bit of a challenge to try to keep our equipment clean and disinfected in some of those homes. And so there are risk assessments that need to be done to decide, you know, maybe on this visit I only take my pen in and everything else I take in I leave there and it never comes out again. Or I'm going to leave the pen, because I get lots of pens at conferences. Okay, so these are examples of when we started to say, hey, are you cleaning and disinfecting your blood pressure cuff and your stethoscope after every use? You happen to carry an alcohol swab with you, so that's something that you should do after each use. And don't bring a thermometer from home to home. Use a client's own thermometer. Otherwise, you're going to have to reprocess that thermometer. And don't carry glucometers from home to home to home. Oh, frightening. We know about the outbreaks associated with reusing glucometers and sharing them. Use the client's own glucometer. Make sure that everybody does hand hygiene before they touch some of these rehab supplies. And bottom line, you do have to have a way of cleaning and disinfecting the equipment. You can use what's in the client's home, but it may not be available. So at a minimum, carry some alcohol with you. Alcohol is always good. Okay, and in clinics, like, do you have a process for cleaning storage cupboards? So I'm mixing a little bit of the environmental cleaning stuff in there, but if it's housing, storing sterile equipment, for example, you do want to follow these processes as well. Now, I'm sure every single one of you has been in a doctor's office with a stretcher that's this wide and the piece of paper that's that wide, right? Right? Like, what is that? I haven't quite figured that one out. And so we are making a statement. There's an expectation to clean and disinfect with a hospital-grade disinfectant. Clean that stretcher down after someone's been on it. That paper isn't magic. It's not a magic barrier. We talked about contract equipment. It's important to document, and it's important to identify clean versus dirty. I'm from Ontario, so I don't know if you're familiar with two documents that we have. One from our Provincial Infectious Diseases Advisory Committee on Cleaning, Disinfection and Sterilization, and the other one on Infection Prevention and Control for Clinical Office Practice. And they have some wonderful tables and checklists and guidelines in there, and it's very helpful to guide practice. Okay, some stories. What's that? Ear syringe. How many parts does it have? One. Oh, somebody says 7. I think this one ended up having 4 because they couldn't figure out how to get the top part out. They couldn't remember how to do it. And this is something that, you know, people don't know to disassemble. And in MDRD, they have beautiful pictures with pieces of equipment that you could look at, and you know how many parts, so you never get that orthopedic reamer again with all the bone chips and blood and whatever in it because they found it was a loose part. We've got to look at some of these items that are being used in clinical office settings and whatever. And so it's a metal piece of equipment. Hopefully it's a stainless steel surgical grade, whatever, that could be reprocessed. Somebody needs to own reprocessing. Is it the physician who uses it? Is there a place that it ends up going after it's been used? Who does it? Is it end up at the end of the day that somebody looks at all these pieces of equipment? There's got to be a way for the pre-clean to happen, the soak at source, keeping it moist, cleaning it, whatever. How should it be reprocessed? And maybe in a busy clinic setting, you should think about that it should be moved to a single-use item and dispose of it. So if we looked at Spalding's and we went to one of our PIDAC charts, we would see, okay, this is a piece of equipment that, according to Spalding, requires high-level disinfection. It's semi-critical. It would be preferred to sterilize it because, hey, if we spent money on all these supplies for a sterilizer, why don't we just sterilize everything if we can, if we have it there and available? So it would look at products and share. Okay, so we got to go a roundabout route. This was on the way to the Boulder Dam, this sign. And let's go to foot care. So Nicole said, Risa, would you talk a little bit about foot care? And I know we've got experts who are talking this afternoon about foot care, and I'm not a foot care expert. But I do know from the 1997 Health Canada guidelines that foot care equipment needs to be sterilized. It's a critical piece of equipment because of the risks of becoming invasive, especially on some of those ooey gooey feet that people end up doing foot care on. The foot with diabetes, poor circulation from PVD, all sorts of reasons why it needs to be critical. So you would need to steam sterilize or do a liquid chemical sterilization. So for a long time, foot care nurses have been doing a liquid chemical sterilization. And the processes can be followed with that. So there's certain things that need to be sterilized, and that would be those multi-use pieces, as I've listed here. And then there are certain pieces that should be thrown out in the garbage, and we should never reuse those rotary tool discs, when they're burring, drilling, because you can't ever clean those surfaces. It's a pretty, you wouldn't be, some of them are paper, they're going to disintegrate. And the ones that are stainless steel, there's so many surfaces to it, it's very difficult you have to have a proper brush, the medical grade brush, not something from the dollar store, and clean it up and then get it through the proper steps for reprocessing. Of course, you've got to discard of sharps the way you're supposed to. And personal protective equipment is involved with foot care. So, one of my colleagues said when she did a talk about PPE and foot care, and she mentioned the importance of wearing an N95 respirator, she was booed. And I hope people no longer boo people who say that you need to wear an N95 respirator if you're doing any of the drilling because of the fungus and it's the occupational health risk associated with. But we have to do, chemical sterilization has been happening for a long time. And I just want to go to the cross traffic that we can run into with making decision as agencies about how you would reprocess something like foot care equipment. And many are still doing a liquid chemical sterilization. And the piece with that is of course it would have to be, the items would have to be cleaned with the detergent or the enzymatic or whatever initially, and brushed and rinsed and dried, and then put into the liquid chemical sterilant that meets all the standards, and with the test strips it would meet it for the amount of contact time that's required. And so at that point, that little piece of foot care equipment is sterile, but then it's got to come out of the liquid chemical sterilant somehow. So in a sterile fashion, it has to be removed from the liquid chemical sterilant, whether it's with a sterile glove or a sterile tongue, and then it has to be rinsed with sterile water, not just once, not just twice. How many times? 3 times. And so how can you guarantee that sterility? And so I'm picturing, I'm holding this item and I'm doing this rinsing somehow, trying not to touch it near any surfaces. And then I do have to air dry it somehow, allow it to dry, and then protect it in such a way as to maintain the sterility to point of use. So it's a challenge to do that well, to do that properly, and to have all the items available to do that, to keep it at point of use. And so steam sterilization would be an easier way to go, perhaps more expensive, and it would be hard to change that practice over from the liquid chemical. And, we don't do surveillance in home care. Yet another study. Any master's students here looking for a research project? PhD students? There's another one. What is the risk? Truly, what is the risk associated with these processes? So, cross-traffic. Here's another one. Wound care scenario. In wound care, clients from the home, a nurse will call ahead, say, I'm coming to do your dressing. Get ready for me. So the clients will actually take their old dressing off and stand in the shower and have a shower and let it go through this chronic wound that they've been trying to heal for a while. And then the nurse comes and they perform the wound care. We teach and reduce. We may teach the client to do their own wound care as well. Now, that wound, at that point, that one isn't sterile. So we have to look at the type of wounds that require sterile equipment and the type of wounds that require clean equipment. Yeah. So an acute wound, acute surgical wound, Yeah, that's going to be sterile starting off. When they first go home and that dressing first comes off, probably sterile, but as time goes on and a wound needs to be healed, it's going to be become colonized in some way. So there are two disciplines that have to get together a little bit more about that, and we need this multidisciplinary conversation. And if you're not doing anything this afternoon, there's another talk about reuse of medical supplies in the home care setting with some draft recommendations. So come to that one. It's at 1:15. So in Ontario, IPAC came up with a statement because we asked for a home health care statement. And it said that equipment or devices owned by the client that are reused in their home must be adequately cleaned prior to use. Good. Home health care agencies may consider reusing single-use, semi-critical equipment or devices. No, I'm serious, don't groan. Yeah, because it's for a single client in their own home, and if they can't afford it, you're not going to leave them without the equipment. There are people who have to pay for their own medical supplies, and the agency's coming in to help them with their activities of daily living, and this becomes that activity of daily living. So if it'd be better to have the piece of equipment, just as long as it makes sure it's clean, and it's clean technique for self-intermittent catheterization in the home. Sterile equipment and using sterile techniques have been shown to cause even more infections than the clean self-intermittent catheterization technique, for example. Or maybe there's a child who needs a feeding tube, has a feeding tube in for years, and the same syringes need to be used over and over again in that client's home. So this happens. We don't want to go the wrong way. We want to go the right way. We used to boil a lot of things. And our original 1998 hand washing, cleaning, disinfection, and sterilization document at Health Canada used a VON recommendation, actually, that said, we boil, so let's keep on boiling. There was no evidence. That's another thing about more evidence, should you boil? That would be helpful, Dr. Siddharth. God, I'd love you to come to our community interest group meeting. No. So boiling historically has been used for high-level disinfection on the same client in the home, as long as the piece of equipment has adequately been cleaned. So it makes a little bit of sense. For those homes, for safety purposes, some people went to microwaving the water and putting the piece of equipment, and that was a bit of a problem because you definitely don't know that it's really reached a particular temperature. At least when it boils, you know what temperature it is. And so we've been talking about this a little bit. And then we did a survey. We actually did a survey across Canada and got all sorts of responses back, but they were all over the map. Some places in Canada are boiling in home care and others aren't. And so really cool effort by the Southeastern Ontario CCAC, Community Care Access Centre, or their local health integrated network, all the people in the area. They got together and created some community guidelines for cleaning and disinfecting instruments used in patient care. So I thank them for letting me share this today. And they're saying boiling and microwaving instruments are no longer appropriate. They say if you use a piece of equipment on a single patient, you don't have to disinfect it between use, but you should clean it and make sure that it's stored dry and make sure that nobody else, little hands or varmints or whatever, gets on the piece of equipment. And they actually drill out the processes for cleaning those instruments in the home and the importance of hand hygiene. Cleaning, drying, wrapping it in something, so wrapping it in a paper towel or maybe a Ziploc bag after it's dry, storing it with the remainder of the dressing supplies. And if you've got more than one wound, then you should have one set of instruments for each wound. So this is kind of making sense. This is practical, realistic sense. And of course, it looks at Spaulding's classification. If it's a critical piece of equipment, then it does need to be sterilized. But if it's non-critical and if it's a chronic wound, clean is good enough. So decisions need to be made about reprocessing. And if you're a community agency, maybe consider some of these. Should the equipment we purchase be single-use or should it, and disposable, or should it be multi-use? So, okay, single-use, clinic. And I have to give you a very graphic example, and I'm looking at my colleague over there. Vaginal speculums have to be cleaned and disinfected after each use, right? They need to be reprocessed. Well, maybe you do a lot of those in a day, and you've got basins full of these, and you don't have time. So let's go purchase a disposable one and see how we do with that. Well, what about the quality of that disposable instrument? Nobody wants rough edges on that piece of instrument, right? So you got to look at some of the qualities associated with these pieces of equipment. Better to use multi-use or go single-use disposable. How is it going to be used and how has it been used? And one of the clinic visits I did, we opened the cupboard and I said, what you got in here? And we opened it up and she said, I have no idea what they're using that for. Why is that there and which physician is using it? And by the way, we had a whole shelf full of them. And when the clinic had opened, somebody had bought this piece of equipment and somebody was using it for something because we're resourceful. If there's something that isn't there for our needs, we'll use another piece of equipment in a way that makes sense to us. So we got to figure out these things. How is it being used? We have to apply Spalding's classification. How does it need to be reprocessed? Clean first, then disinfect or sterilize. Do I have the right products, the right space? So you've got to think of that reprocessing area. Do I have the MIFU, manufacturer's recommendations for use, for reprocessing? And how do I really know it's clean and disinfected or clean and sterile? Because I got to do some of these indicators and integrator things. Do I know what I'm doing? Does anybody in the clinic setting know what they're doing? Does anybody in that particular home care agency know what they're doing with reprocessing? And are they doing it properly according to the best practice guidelines? And if they don't, they better figure it out and maybe go disposable for now. So, no bull. No bull. You've got some options that you need to consider. Disposable medical equipment and devices, you can go that way. But be sure you get good products. You look at the quality products, look at the choice of products, and look at maybe the greenness of the product with this environmental concern that we all have. I have to tell you that when the Community Health Interest Group first started, it was great finding each other across Canada because we were all sole practitioners in our agencies. And so I got a call from my colleague on Vancouver Island. She said, oh, Risa, I don't know what I'm going to do. There is this product that they purchase for the physiotherapists. It's called a transfer belt. And the physios need to get people up and out, and after ortho surgery of some sort, they need to get them ambulated. And so it'd be really expensive to have disposable ones. So we're just going to buy one belt per physiotherapist, and they can go from home to home with the same belt. And she said, I went, oh, but how would you clean that? How would you reprocess that belt that's going from home to home to home? And it turned out, and I said, well, what's it made of? What's the manufacturer? Of course, manufactured. It turned out it had to be laundered. How are you going to do that from client to client? Or you go disposable, or you go do a cost comparison. What are the costs going to be? And in Ontario, we've started a reprocessing project because the community people said we need help with reprocessing, particularly in clinical office settings. So we don't even know what to buy. So we're looking at things like, how would you get started if you've never done it before? How would you do it? What are the steps? What are the supplies you need? What knowledge do they need to know? And so we're going to help with that. The education and quality monitoring is so important. Or maybe you could build a relationship with the local MDRD. So maybe a nursing agency has a bunch of foot care equipment, and maybe they can have a contract saying, could we transport it to your facility in the manner according to CSA standards, would you reprocess our equipment? And it's a collaboration between the community setting and the hospital setting. Do you think that's possible? Or sometimes foot care might be provided and a public health unit has a clinic close by. Is it possible that the equipment goes through the sterilizer there? So somehow build a collaborative relationship. And we also know that there are companies that are starting to do that for you. Something to consider too. It's expensive. So you gotta come up with some recommendations for this. So how about starting with, if you're looking at your, if you want to put out your fire, if you're looking at building your policies and procedures for reprocessing in the community, identify the equipment that you need to use in the delivery of care, how often, ascertain how often it needs to be cleaned, the frequency of reprocessing, what those policies and procedures are, and then review it. Look at that. Look at your products and your product selection. Start auditing. Maybe you don't even know what you don't know until you do some auditing, and then continue to audit and start that quality improvement cycle. And of course, use the hospital grade standards and the medical grade products. So patient expectations are the same regardless of where healthcare is delivered. And it could be delivered at the local Tim Hortons, it could be delivered in a church basement, it could be delivered in a client's home, it could be delivered in a clinic, it could be delivered in a homeless shelter, many places it could go. And of course, we need to follow those principles of reprocessing, and do join the Community Healthcare Interest Group of IPAC Canada. And we had a hospital person attend our meeting, and she was very, very helpful yesterday. She was. So, any questions? Comments? Stories?
Songs?
Songs? Oh, good. Ooh, hope I can answer it.
I work in public health, and like you, I expect physicians' offices or dental clinics, and only whenever there's complaints. However, what I find irritating is that the colleges of physicians or college of dental surgeons or podiatry don't routinely. Everyone hear that? Okay. Don't routinely audit or inspect these settings. And as it stands, I'd probably prefer my local tattoo artist sterilize medical equipment versus a clerk in a physician's office, because I at least know that they're inspected and we provided education. So
Yeah.
I just wanted to make that comment. So.
Yeah, and you know, I'm with you in that comment. And in Ontario, we've actually developed a relationship with our College of Physicians and Surgeons of Ontario, and have spent time with the peer assessors as well as the assessors who go in and do some of those audits. And we've provided some education for them. So it's coming, and we hope with this IPAC and the physician's office document as well, that people will start looking at it. It'd be great. Are you from, which province are you from?
Ontario, Eastern Ontario Health Unit.
Yeah,
So.
exactly.
Yeah.
Exactly.
By the way, I have some great pictures for you if you ever need them.
Yeah. Anything else? Lunchtime.
Lunchtime. Thank you, Risa.
I didn't see any.